Welcome to Healthy Conversations, an open discussion with healthcare experts about what we've learned from the front lines and how it's transforming our industry in real time. I'm Daniel Kraft. It's remarkable that we can develop and distribute multiple COVID vaccines less than a year from the start of this pandemic. Yet at the same time, we're reminded that the distribution of healthcare remains woefully uneven, particularly when it comes to women and even more so with women of color. Disparities result in the U.S. having the highest rate of maternal mortality amongst developed countries, a rate that's actually still rising. Let's unpack the contributing factors and learn how healthcare providers are addressing the impact of bias in all they do.
Back in the day, women weren't even necessarily intentionally included in clinical trials, right? So all the findings, how we think about heart disease, drugs, et cetera, we learned it on men. We assumed that it applied evenly to women. That has disadvantaged women, right, to really understand why their physiology might be different, why their disease presentation might be different.
I trained in traditional internal medicine and pediatrics, and I think the term women's health was around, but maybe let's start with some level setting.
So when you think about what is women's health, a lot of people think that is just OBGYN care, but it's really broader than that. It's sort of thinking about women over the course of their lifetimes. Much of it sits in reproductive health, right? So adolescence, procreation, menopause, these areas that most people recognize as really unique here to women. But there's also this issue of more chronic disease care and the delivery of it for women. And women have, I think, some unique challenges when they access care.
Yeah, there's certainly, for many women, including my wife, they're really the CMO, the chief mom officer or medical officer for the family, for the kids, for their parents.
Yeah, I mean, we sometimes laugh about that, but it's true. Like women make 80% of the healthcare decision-making for their families. And that's everything from picking an insurance plan, picking a pediatrician, and the geriatrician for mom, right? Thinking about the hospitals and the facilities that we go to, thinking about, coordinating the care, getting the vaccinations done for one kid and, trying to find COVID vaccines for one's mom.
Really interesting layers coming together. But let's zoom back again on maternal health in general.
Half of the pregnancies in this country are not planned. And when they're not planned, it means you lose your opportunity to optimize diabetes and your hemoglobin A1C, which is associated with birth defects and all sorts of bad things. You lose your ability to control hypertension, weight, connective tissue disorders, and a whole range of things.
And it seems like an opportunity from preconception all the way through delivery and beyond. You have an opportunity to connect the dots.
So one of the examples that I'm working on now with a team of creative people at CVS Health is to look at this issue of a disease in pregnancy that's called preeclampsia. So preeclampsia is this kind of weird form of hypertension. It only happens in pregnant women. We know what the risk factors are, but when you get preeclampsia, it tends to sort of manifest itself very quickly, and the only treatment for it is delivery. It's a major cause of preterm birth and low birth weight and a significant driver of maternal death in the country. What's neat about this is, the preventive step for preeclampsia is low dose aspirin, 81 milligrams of aspirin. It costs $3 or $4 for an entire treatment course. It is safe. It is readily available. We can identify women who have risk for preeclampsia and send them both, educational information about risk factors and symptoms, but also give them the bottle of aspirin.
In general, here in the United States, very developed nation, but we're still quite low down on the spectrum in terms of risks and outcomes in both prenatal and postpartum care.
We rank somewhere around 35 in the world in maternal mortality. Our maternal mortality rate is actually increasing compared to other countries. So, and then when you look at the experience of Black women, for almost every measure of maternal and child health, Black women perform worse. We have about 3 times the rate of maternal death, twice the rate of infant death.
Clearly, race is one component, but maybe you could help us dissect what really, beyond the core racial element, really drives the disparities.
The drivers of the difference in clinical outcomes in maternal and child health is explained only partially by risk factors, underlying risk factors. It's also only partially explained by the systems of care that patients access. It is also explained by bias and racism. And there's now a decent amount of literature that sort of points to that. We need to do more, but we also need to give patients tools so that they can recognize that, get some allies, and sort of fight through it. We are also embarking on non-biased training for our clinical people, our nurses and the clinical staff that have interactions with our patients.
We've talked a lot about maternal care, but there are many other aspects to women's health that may be overlooked. What are you and CVS doing to maybe innovate in this area more broadly?
So we are looking at sort of transformation of healthcare in a lot of different areas, rethinking about primary care models and how we can be, collaborators with physicians, how we can help fill some of these gaps in care, especially in sort of remote areas and other geographies where clinicians are just not there. I think COVID has really shown us that, right? Who is the tester? Who are the vaccinators? How can we do this equitably? What kind of gaps can we fill? We are really trying to listen to physicians through literature, through data, through clinical utility studies, et cetera, to identify where things start breaking down and where we can sort of help, heal, if you will.
The issue of bias in healthcare is certainly complex. And next, we'll talk to an expert with firsthand experience, grappling with large institutions from the inside, working with systems in place to improve women's health through public policy. You're trained as a classic OBGYN, but you've really branched out to look at a whole bunch of other elements impacting women and health equity in healthcare. And you were one of your big steps was to move to the Veterans Administration, the VA. I'm wondering if you could share some of your personal highlights and insights from your time at the VA.
Yeah, I've always been interested in thinking about how to ensure women have access to comprehensive healthcare, right, throughout their entire lives. The VA actually saw an increased number of women veterans utilizing the healthcare system and really had to undergo a transformational shift from taking care of predominantly male veterans to really transitioning sort of across the gender landscape to incorporate women as well. And so that was really very exciting to really think through from a health systems perspective, how do you provide care to a population that's growing? I recall, talking to veterans in the VA when I was practicing and just, imagine, being a woman who served and coming to the VA and being asked, where's your husband? Where's your father when you're the one that's been serving in the front line? So really a cultural change around recognition of the various faces of veterans and how veterans can look, and beyond just expanding gynecology services or thinking about obstetric services, but really thinking across mental health and primary health care and neurology care, et cetera, like how to make sure that there's the capacity from a clinical training perspective, but also from a systems perspective to care for the broad spectrum of this new veterans that were coming into the healthcare system.
Given the VA is a big system, and change sometimes takes a while with leadership and politics in the mix, any lessons there from shaping your own perception and attitudes towards women's health and how to help shift those in a large organization or society writ large?
So there are many reasons why we may have these disparities. I would say the top four: Black women, for example, don't get the care they need before or after pregnancy. A disproportionate number of Black women are uninsured. And so really addressing affordable universal health care is critical. And when we think about societal racism as well, racism is baked into American life, and our healthcare systems and communities are no exception. And so how do we address social inequalities that are upstream, for example, and also downstream? Black moms are more vulnerable to poor health and have less access to primary health care and access to healthy foods in their communities, or reliable transportation, safe neighborhoods with good schools and decent jobs. And so that's really critical. And the third is, when Black women seek care, they're often not taken seriously, regardless of how educated we are or how much money we make. Black moms don't get the same respect or attention, and there's data to show that. So we need to better understand that and understand how structural racism manifests.
We have a lot to learn and a lot of improvement to make. And you've obviously this incredible clinical background and systems background in trying to instigate change. We know that the United States, despite spending the most per capita per, let's say, individual or patient, is ranked quite low, particularly in maternal fetal issues. But we have lessons from around the world, some spending far less per individual. Can we learn some best practices or examples from other countries in maternal health that particularly impact outcomes, and are any of them starting to be implemented here at home?
This may seem like an intractable problem, like what can providers do on the ground for some, or health systems do on the ground. Investment in community health workers and doulas, I think, is really, really important when people have doulas who can advocate for them during the birthing process and before and after. That's been shown to save lives and improve healthcare. It's important for people to question their own assumptions about people that come to see them. I mean, it's challenging, it's not fun, but it's important to do, and it's important for growth as well.
The pandemic has intensified the attention paid to disparities in our healthcare system and the necessity for fresh approaches that respect differences in physiology, culture, and economic circumstance. Part of the answer lies with exploring new ideas, but most of all, it's about recognizing these inequities and recommitting ourselves to finding solutions and correcting our own behaviors. Never easy, but it's necessary to challenge ourselves in order to improve outcomes across the board.